So the main topic of today is COVID-19, home versus ICU management. As a person from a critical care background, I would majorly talking about critical care and finally go to home care. I'm just going to do the reversal today. So my name is Anu. They have already introduced me, and I'm just a passionate critical care nurse. So I welcome all the nurses, administrators, and fellow friends and people who are there around with me to watch this webinar. So the objectives of today's webinar, we're going to just look and understand what exactly is coronavirus, what is this happening all around the world, how to illustrate the pathophysiology and its mode of viral entry into a human body, what exactly happens, to identify the early and the late symptoms, to leverage the acute and the critical care options available. This is a time where we really don't know completely how to handle it, or we are not completely sure of what exactly this virus is battling with a human life, but we're just going to understand from different researchers and methods which are out in the market on what are the options available. And then we're going to look at home quarantine, what and how we can make sure we're safe at home, and finally looking to brainstorm ahead on the future. So to introduce, this is the spooky virus that's actually caused a complete stir in 2020, and the whole world is trying and finding a way to move forward. So what exactly is it? How does it come and enter into a human body? Let's just quickly watch this. So that was just a video of how from a human being or a human host, it gets to the inner bronchus, and now it's commonly known as COVID-19 or SARS-CoV or coronavirus. So the whole story didn't start very long back. It just started very recently on 31st December 2019. WHO was informed of a cluster of cases of pneumonia of unknown cause detected in Wuhan. Wuhan is just a place in China, and it is a family of viruses that was detected in the year 2003 in China again, and which was manifested by SARS. SARS is severe acute respiratory syndrome. And again in 2012-2015, it was widely seen in the Middle East and known as Middle East respiratory syndrome, which was thought to have spread from camels or bats. And we are still not sure completely of what exactly happened with corona, but it's still understood that it's something to do with bats or mammals or seafood. The incubation period of the current coronavirus or the COVID-19 is thought to be a maximum of 14 days, with a median between 4 to 5 days from the start to the onset of symptoms. So what exactly happens? And how does this virus behave differently in a human cell? Let's just watch a quick video to understand that.
The coronavirus must infect living cells in order to reproduce. Let's have a closer look. Inside the virus, genetic material contains the information to make more copies of itself. A protein shell provides a hard protective enclosure for the genetic material as the virus travels between the people it infects. An outer envelope allows the virus to infect cells by merging with the cell's outer membrane. Projecting from the envelope are spikes of protein molecules. Both a typical influenza virus and the new coronavirus use their spikes like a key to get inside a cell in your body, where it takes over the cell's internal machinery, repurposing it to build the components of new viruses. When an infected person talks, coughs, or sneezes, droplets carrying the virus may land in your mouth or nose and then move into your lungs. Once inside your body, the virus comes in contact with cells in your throat, nose, or lungs. One spike on the virus inserts into a receptor molecule on your healthy cell membrane like a key in a lock. This action allows the virus to get inside your cell. A typical flu virus would travel inside a sac made from your cell membrane to your cell's nucleus that houses all its genetic material. The coronavirus, on the other hand, doesn't need to enter the host cell nucleus. It can directly access parts of the host cell called ribosomes. Ribosomes use genetic information from the virus to make viral proteins, such as the spikes on the virus's surface. A packaging structure in your cell then carries the spikes in vesicles, which merge with your cell's outer layer, the cell membrane. All the parts needed to create a new virus gather just beneath your cell's membrane. Then, a new virus begins to bud off from the cell's membrane. Now, with the virus spreading in your body, how can you develop pneumonia symptoms? For this, we'll have to look into your lungs. Each lung has separate sections called lobes. Normally, as you breathe, air moves freely through your trachea or windpipe, then through large tubes called bronchi, through smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Your airways and alveoli are flexible and springy. When you breathe in, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries, and then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Your airways catch most germs in the mucus that lines your trachea, bronchi, and bronchioles. In a healthy body, hair-like cilia lining the tubes constantly push the mucus and germs out of your airways, where you might expel them by coughing. Normally, cells of your immune system attack viruses and germs that make it past your mucus and cilia and enter your alveoli. However, if your immune system is weakened, like in the case of a coronavirus infection, the virus can overwhelm your immune cells, and your bronchioles and alveoli become inflamed as your immune system attacks the multiplying viruses. The inflammation can cause your alveoli to fill with fluid, making it difficult for your body to get the oxygen it needs. You could develop lobar pneumonia, where one lobe of your lungs is affected, or you could have bronchopneumonia that affects many areas of.
So, cutting down the big story short, all that the COVID is doing is to fake and attacking our body, thinking it's a normal genome of our body. And our body accidentally accepts the receptors through the ribosomes, and we allow them to enter our body. And once it allows, it weakens our immune system, and we are at a stage where we are not able to fight back. And if we are really strong, that's why we become asymptomatic or just carriers of the disease. So going ahead, what are the common symptoms? So as we already said, 2 to 14 days is the common incubation period, and people have symptoms between this period of time. And it can be from fever or chills, cough, shortness of breath or difficulty in breathing, dyspnea, which we say, fatigue, nausea, vomiting, diarrhea, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion, or running nose. Most of the symptoms can be faked, or in other terms seen as a differential diagnosis for influenza, common cold, or any other normal viral infections, or also some other disorders which we really don't know, or in people like old age, comorbidities, these can be missed. So what exactly are the common symptoms? We can see that the common symptoms presented are fever, cough, shortness of breath, which needs an alert, sore throat, and headache. And by research from different sources say that loss of smell, abdominal pain, nausea or diarrhea, myalgia, and definitely any person who doesn't even have corona is anxious today. So that cannot be exactly seen as a symptom. So the above symptoms have also been associated for certain cases. So what exactly are the diagnostic studies? Before moving into direct PCR test for corona, which everybody knows, I'm not going to include on that, what are the other studies that can really show or prove down? So hematological studies in labs, usually this surprisingly, unlike other infections, the WBC, the blood count, seems to be within normal range unless in a later stage. The coagulation profile is quite altered in most cases. The D-dimers levels are seen to be high. The inflammatory markers are one of the best ways to see in where the CRP is quite high. The procalcitonin is elevated, which also is similar to sepsis. So it's actually quite tricky how COVID symptoms or specificity is quite related to many other disorders, which makes it more harder. So specific to COVID, we definitely do a nasopharyngeal swab. So you get a direct swab from the nose. It's done for all conscious patients. If intubated and we need an aspirate, you can of course take a suctioning irrigate aspirate or a tracheal aspirate. And in some cases, bronchoalveolar lavage or an induced sputum is also done, but is not recommended because of the high risk of transmission from one person to other. This is a general flow chart that shows how a patient seen can be evaluated from admission to suspected coronavirus. So the initial tests, like how we spoke exactly, going to radiological studies, nasopharyngeal PCR, doing a CBC count, a CRP, a procalcitonin, and also making sure that other markers important like echocardiogram and ECG should not be missed, because these symptoms are also seen in a late COVID affected person. So if it's negative, definitely you're going to go to an alternative. Make sure you repeat the PCR if required. CT scans are recommended in certain countries, and it shows specific findings which can help us to make sure that the person is tested positive, even though the findings are negative, but the person is an invisible host or carrier. And if it's positive, definitely we're going to look in forward treatment line. So going ahead of radiological studies, the chest X-ray and CT, I just put CT together, both shows ground glass opacities, which are very particular and typical to COVID. And as the videos we saw in the video of explanation, it affects the alveolar. So more it is into the basal alveolars. So the chest X-ray shows glass opacities in peripheries of the lungs or into the basals of the lungs. Lung ultrasonography, not recommended in all the countries, but WHO and CDC does recommend it because of the specific marker lines that can be seen. Bronchoscopy in an ICU is one of the available choices at a high risk. Typically in an emergency room or in an intensive care room, when a person comes with distress, ABG is one of the first line of investigations we recommend. Not in COVID because of the reasons that it is not specific to any specific test, but the altered level of lactic acid or the lactic acid levels are usually elevated in a COVID client. So what exactly is the management? So I've just put it as general because in an intensive care, I believe, again, it's a multidisciplinary team. It's not nursing or physicians. We all work together, and every role, every individual management or intervention becomes equal responsibilities of everybody. So the cardinal symptom which you say is that they can't breathe in spite of putting them in any position. They're completely anxious and breathless and exhibit symptoms of difficulty. So maintaining the oxygenation is one of the main priorities initially when a patient comes in. So maintaining oxygenation to maintain a saturation above 90%. So this can be done by oxygen therapy, first line of choice, nasal cannula always. Using a high flow nasal cannula is recommended if you have a negative pressure room, but if it's in a non-negative pressure, always go for a low flow nasal cannula. 100% non-breathers mask or using non-invasive positive ventilation are recommended highly before going to options of invasive ventilation. And in non-invasive, definitely using CPAP and BiPAP have shown equally good and positive results. So what exactly going to nursing specific? What exactly nurses can do? Make sure positioning, Fowler's positioning to make sure the secretions are but quite down is requested or is recommended with intermittent awake proning. Proning is actually there in respiratory medicine for a long time, and it's proven to have a very beautiful benefit on an awake patient, a conscious patient before, because we never used to do awake proning techniques before. More on an intubated patient, we used to give supine proning positions, but in COVID specifically, giving an awake proning technique has shown to pull down the secretions to the other side, opening the bronchus and the alveolus for better saturation or better oxygenation. So awake proning is a recommended technique which can be given for a frequency of 8 to 12 minutes to 15 minutes maximum, and giving them intermittently on a regular basis. Vital signs monitoring. So any critical, all the readings must be taken initially. So temperature for pyrexia, blood pressure. The blood pressure is usually into an hypo state, and that's why some studies have recommended stopping ACU or ARBs if the client is on an antihypertensive drugs before, because that can alter the way the medications can act. Respiratory counts to check and alter for dyspnea. Saturation levels, as we spoke and we seen, it's mainly affecting the lungs. So definitely the clients will have hypoxia. So maintaining saturation is one of the most important critical reading that we have to look at. Before going into advanced intensive care, maintain large venous access, at least 2 large bore cannulas. Prefer more into the central rather than the peripheries. Make sure you do conservative fluid management. Again, typical to other respiratory disorders, we're not trying for a fluid challenge. You're not going to overload the lungs. So we're going to try for a conservative fluid management to make sure that the client just needs adequate at a body weight that's calculated. Urine output monitoring is very important as well, along with laboratories of creatinine, because one of the main complications of multi-organ failure that's seen is renal failure, and the client can go to an immediate acute renal failure, which can be non-reversible. PPE, so it's definitely an infectious disease. It's a droplet infection, so it's a standard to use all the standard precautions in place with complete PPE. So PPE in different books have different ideas. You can use a complete biohazard kit if you have, which is available in your hospital, but basically making use of at least 2 or 3 triple filter common mask, or an N95 if we have, making sure you have eye goggles with eye shields and protectors, or eye visors, making sure you have fluid repellent, high full gowns. Some suggest using shoe covers, but it's not mandatory if you have a good disinfection guidelines. Negative pressure rooms and protocols are extremely highly recommended if possible, but if not, making sure good disinfection, hygiene techniques are recommended at that stage. Avoid fluid overload, definitely. And as I said, acute renal failure is one of the major complications. So nephrotoxic drugs to be avoided at all stages. And that's one of the reasons also why ARBs and ACEs are stopped at an early level. High flow oxygenations are avoided because, as we saw, the alveoli is already fluid filled. It cannot probably take the pressure of a high flow oxygenation. Bronchodilators is also not highly recommended, and it is better to use a meter dose inhaler if required. So going further, if the client needs intubation, so if the client is intubated, so using a ventilator associated pneumonia bundle, making sure the client is elevated frequently, secretions and suctioning are done, using strict. For COVID, I would definitely recommend a closed suctioning method so that you have complete no risk of transmission of the aerosol procedures that you're doing, making sure you have glycemic controls, and also taking care of the enteral feeds and supporting it with PPEs. So all the steps of the ventilator associated pneumonia bundle are to be followed, including DVT prophylaxis. So strict fluid monitoring. Instead of ABG monitoring, we recommend, or most of the recommendations internationally suggest using EtCO2 levels to make sure that the oxygenation level is perfect. Glycemic control for non-diabetic clients as well is important, starting on enteral nutrition, DVT prophylaxis. I'm not going to all the small steps that we need to take in between because it will take a longer time of presentation, but yes, DVT prophylaxis if the client is intubated is important. Closed suctioning measures, as I said, medications definitely come with a combination of drugs in each part of the world, but basically antipyretics, acetaminophen of 1 gram every 6 hourly IV is suggested to make sure that hyperpyrexia is controlled. Antibiotics, azithromycin is the first line of drug. If not, in a patient with pneumonia or severe sepsis, vancomycin or linezolid is the recommended drug of choice of antibiotics. Opioids, definitely client is on ventilator, needs sedation, so propofol or haloperidol is suggested. Steroids is not completely recommended, but partially recommended. If required, dexamethasone can be used. Infectious waste management protocols are important for the reason it is a transmission-based disorder. It is a droplet-based disease, and any infection that's coming in and out has to be stopped. Stopping the chain is the most important part, because as hospital or at home care, we are trying to minimize the risk. So infectious waste management protocols are a strict reminder and need to be strictly followed with the backup of an infection control protocol. No visitors, strictly, to make sure, again, to reduce the risk of transmission. So going to lines. So going further, if the client requires central line or arterial line, making sure the bundle managements for lines, so central invasive lines, are more followed. Strict sterile techniques to be kept, and urinary catheters are also important to avoid further risk of infection in an ICU and making it more of a hospital-acquired infection. It is recommended to use viral filters or HME filters. We do use bacterial filters for ventilators, but using it, not just using it, making sure you monitor it on a daily basis, or 12th hourly per shift, and changing it if it's soiled is recommended. Minimizing strict human or door exchanges, maybe a nurse, physician to a charge nurse to housekeeping. Make sure you monitor how many exchanges of room or door is happening. Make sure like lab and other things are done through single door system, so that there's less exchange of infection materials and also ventilation system. Labeling all the biohazards as a hazard is a priority. So going ahead, so the first major complication of a client who's intubated or who's in a severe stage is septic shock. So septic shock generally is a life-threatening organ dysfunction caused by a dysregulated host, which has already proven to have an infection. And definitely in this case, the host is the virus that we're talking about. So the symptoms are a bit more extensive or more complex. So the client can show severe dyspnea, hypoxemia, coagulopathy, multi-organ failure. Again, as I have repeated quite several times, it's more of a renal failure, less than hepatic or any other signs and symptoms. Altered mental status with confusion and anxiety, tachycardia, acidosis, thrombocytopenia are seen. So the mode of management here shifts more into a septic shock management. So again, as I said, and I'm repeating, it's antibiotics. Maintaining a mean arterial pressure greater than 60 to 65 is important. So a fluid challenge can be given if it's severely hypotensive, but not on an overload. And crystalloids or ringolactates are the fluids of choice. Vasopressors, to make sure you maintain the vasoconstriction, dilation, and the blood pressures within the body, maintaining mean arterial pressures, and several other things. Norepinephrine is the first drug of choice of vasopressors, followed by vasopressin. Epinephrine can be used, and dobutamine only if you need to increase cardiac output. So the next important thing is it's associated with ARDS. So it's acute respiratory distress syndrome. So we're going to follow the same surviving sepsis campaign guidelines, which have been specified. So not just ventilation, perfusion is equally important. Perfusion and ventilation need to go hand in hand. Intubate and extubate in a negative pressure room as much as possible. Staff should don PPE and preferably powered air purifying respirators, and minimize the number of staff in a procedure. And this also applies when you have a code blue or like situation where a team has to arrive minimize the number of people entering the room and are required to be there along with the patient. So in terms of ventilation, the main strategy is a low tidal volume, maintaining a low tidal volume. So when it's usually 6 ml per kg that you maintain for a tidal volume on a ventilator, make sure the tidal volume kept minimum at a 4 to 5, 6 if increased, if needed. Maintain the barrow pressures. The airway pressures are need to be monitored in the ET tube, and keeping it less than 30 is highly recommended. If you find that the pressures are increasing, make sure you reduce the PEEP or reduce the tidal volume to stabilize or balance the increasing barrow pressure, because the more you're going to cause increase in the barrow pressure, the more it's going to cause collapse of the alveoli or atelectasis, which is exactly not we want. So use of PEEP to oxygenate. So just start lowering the PEEP or using a PEEP of less strategy with the wide tidal volume will help it. So as a nurse, why is it important? Because we are the ones who are monitoring the ventilator, and it's important for us to know if the pressures are increasing. Definitely, I don't think in many countries we are allowed to monitor or change the options available on the ventilator. But if you know that the alert is because of the barrow pressure, it's important to alert the physician immediately. The alternative modes of ventilation preferred are always, again, volume or pressure modes, and use of recruitment manuals. So recruitment manuals here means giving an inspirational hold. So increasing the inspiration hold and keeping it for a minimum period of time, allowing the recruitment to happen and allowing the alveolus to get that oxygenation and then reversing back to the normal. This is a technique which has been seen to help in providing the pressure to open up the collapsed alveoli. So proning not only for conscious patients, also in ventilated patients. Consider about 12 to 15 hours per day on an alternative. It is very hard in an intensive care to do a proning techniques due to several factors of hemodynamics, but still watch for hemodynamics and ventilation. And first hour post proning, because that's the most hardest critical care procedure to do. When everything is prone, your ET tube to everything is upside down. It's very hard to monitor the lines and measures, but it is definitely shown to have a better effect. So other therapies, we're not really going into pharmacology because it's not completely into ours, but standard intravenous immunoglobulins, giving plasmas, and also trial of lopinavir and ritonavir drugs that are associated with ARTs for AIDS are also being trialed and found to be successful. As we see every day in the US, we have talks about hydroxyquinolones. Some studies say it's helpful and some not. But again, I've just put it as other therapies. So use of antivirals, Tamiflu is given, and other drugs like on a basic level are given also. And immunomodulators like cytokines are given to fight against the cytokine storm. We're not going into extreme details of that, but basically that's all what we can do in an intensive care. And once we find that the oxygenation is improved, there are high chances that the client is extubated and brought back to normal life. And once the client is extubated, it's recommended to have CPAP or BiPAP for some period of time to push out the fluid and help in breathing. So now, prevention and home management. Isn't it a lot better to prevent it and try to manage it most at home? So the steps at home is quite simpler. Stay at home. Just don't go outside and catch the virus and cause harm for yourself and to the community. Avoid crowded areas as much as possible. Just be outside for what is necessary. Wash your hands. So hand hygiene, as we always say, it's the single most important procedure to prevent infection and to prevent cross-infection. So hand hygiene hands are the first carriers of most of the infection. So wash your hands as much as possible. Follow the 5 movements of hand hygiene suggested by the WHO. They're universal, they are important and obligatory at all times. Disinfect all areas of household. So in a community, making sure that disinfection is very important. As studies show, that the virus stays on surfaces like paper, plastic, and wood for more than 12 hours. And it is possible that we can just kill it out by disinfection. And laundry by just washing. So disinfect all the areas of the household, including doorknobs, normal tables, all, all common cutlery, and areas that we usually use, using things that we're using daily on a daily basis, like mobiles, pens, books. What else can you think of at home? Everything needs to be disinfected on a regular basis. Forbid more formites contact, sorry. So formites are seen to also be a form of reason why the spread of corona is seen, even though the studies have not completely proved it. So any kind of formites and contacts, so anything that comes from outside, make sure you wash it, clean it up, and especially in an intensive care unit, use of stethoscope is requested to be avoided as much as possible for format contact. Use of mask. I have actually intentionally put use of mask if needed, because in the country that I am, we were advised not to use mask every time. We were asked to use mask only if we are in contact with a probable suspected or a positive client or a patient, and not on a regular basis. But certain countries do recommend, where there's more spread of global COVID virus, to use it on a regular basis. Please do follow the recommendations and guidelines of your country and the Ministry of Health of your place. So I've not specified into detail, and extra care for sick, pregnant children and old age is definitely requested. So this is all that's in our hands, which we can do. So what ahead? The general routine: eat healthy, drink enough water, and hydrate self, because it is proven that dry self, or keeping ourselves more dehydrated, is an easier way where the virus can enter. So drink water and hydrate self. Take additional doses of vitamin C and immunity boosters required. Exercise, and definitely report if you note any symptoms. Do not delay. Like in New Zealand, if you have a symptom, you need to contact through a phone on a helpline before going to the hospital. So in certain countries, they ask you to go directly to the hospital. Whichever is the protocol, make sure you report. Speak to a physician or call for help. Call for an ambulance if you think you're really sick or need attention. So this is all that we have that we can do. What is the future? We're all waiting for the magic miracle of vaccine. So the corona vaccines are still in trial phases. Some antibody testings are already in the market, and they've already started in certain countries. Certain countries have opted for herd immunity, where they're allowing the spread of the virus to create a herd population community antibodies in the system. Certain countries are requesting lockdowns and complete isolation to make sure they completely eradicate. The methods may vary, but the target or the goal is the same, to make sure that we fight against and stop the chain of this virus. So that's all for me. So it's open for questions.
We have few questions, Mrs. Anu.
Yeah.
So the first question is there any vaccines update for COVID-19?
Yeah, just like how I've told you, there are certain vaccinations that have come up. Certain countries have started trialing the phases, but an actual vaccine has not yet been publicly issued. Vaccine trials are always a long-term story, because vaccines cannot be coming up in 10 days or 15 days. This virus has just come up like 3-4 months back. So whatever vaccines are available or studies that have proven, there are some studies that say that a vaccine has been found up in US, in UK, and also in some part of India, which are all in a trial stage, and proper research has not yet been available. So I would still say we are waiting for the magic miracle.
Thank you. And the next question is, when should I return to work after I have been sick with COVID-19?
So if you mean you're sick, I think you meant that you're positive, you're infected, and you know that you have a COVID virus infected. So naturally, as incubation states, it's 14 days. The worldwide recommendation is also that since the onset of symptoms for 14 days maximum, and after that, you need to do a repeat test 2 days
Yeah.
prior to 14, so around 10 to 12 days, to see how much you've progressed. If you've turned negative, you're safe to return to work. If you're still positive, I think you need to still consult and go for higher therapy.
Yeah, thank you. And the next question goes
14
as,
days. So the answer
so
was that you can return back to work after 14 days if you're negative. If you're still positive, you need to wait for your next trial to check, make sure you're negative, and then you can return back to work.
yeah, thank you. The next question, just a second. The next question goes as, can you share practical steps for properly attending to your own needs so you can sustain care for others? Like
So
practically,
practically in steps, like in my place, in my situation in New Zealand, so I will say how we did it, because I'm happy that we are in that part of the world where we could control coronavirus completely. It's completely come from level 4 to level 2, and probably we are going to level 1 in a week. So we were given a lockdown completely from the start. So I had to work from home. I'm also high risk actually, currently for some reasons. So I had to restrict myself to stay at home. Most of my shopping were done online, so I had to make an online shopping if possible. Or one member of the house has to go out, and that person has to make sure they keep up hand hygiene. Whatever you bring in, make sure you wash it, clean and disinfect as much as possible. And any exposure from outside to inside, that it's your house, it's your space, the people around in your house, educate them, create awareness, especially for kids, including kids. Like I have a 4.5-year-old daughter, so she knows about the coronavirus and why she can't go to school and why she can't go to park, sorry, uh, why she cannot go for shopping outside. That's because of the virus. So education plays an important role. Awareness, there are a lot of fake rumors that are coming around, so always make sure you get the update from specific reliable sites like WHO, CDC, Harvard, Stanford, or NHS, or your Ministry of Health guidelines of your country. Like we in New Zealand, again, we have a website that speaks specifically for COVID in New Zealand. So any queries, we can always ask them, and we have a helpline. So these are few things that you can do. Again, as usually women at the house, you have to disinfect, make sure you clean up everything. Wash your vegetables. They say wash vegetables or fruits, put it in water for a longer period of time. I also personally don't do everything, but yes, the more you do, the much the better. And any kind of clothes, laundry, as healthcare workers, whatever you take out, make sure you change your clothes before you leave your work. Put it in a soluble, water soluble bag if you have, or a disposable bag that you want to put in. Change yourself, make sure you put it straight to your laundry washing, so that you don't increase the risk of transmission.
yeah, thank you. Okay, so the next question is, what is choice of antibiotics if the patient is in ventilator?
So yeah, so the choice on a non-ventilator is usually azithromycin, but if azithromycin is the basic and it's usually used, and the blood cultures are definitely done and the sensitivity is seen, the next choice of drugs given is vancomycin and linezolid. I think I already also put it in a part of the presentation. So vancomycin and linezolid are the drugs of choice.
Yeah, I hope the questions are done, Mrs. Anna. Thank you for explaining each and every questions. Yeah, so we have another question asking for what is the duration of testing COVID?
There's no actual duration specified for testing COVID, but if there is no symptoms, there is no recommendation of testing on an anxiety or in a self-panic mode. You don't have to test for COVID on a regular basis. But if you have any signs and symptoms, and the physician or the physician feels that you seem to fit the criteria of headache, running nose, sore throat, fever, temperature above 103, then definitely testing is highly recommended. And if you're positive once, you definitely have to test again to make sure you're negative.
Yeah, thank you. So, thank you, Mrs. Anu.
Thank you.
Thank you. Okay, so I hope we are done with this session.
Yeah.
One last thing, Mary,
Okay.
if I can speak. Actually, at the end of this, I've put some references. So sorry, I couldn't actually go to the references. So the references are actually taken from CDC, NHS, WHO's website. So if you need more information, or as a nurse or an administrator looking for more information, these sites are very much useful. And also there are some courses online available at WHO, CDC, Stanford, Harvard, and different sites, and the NHS. And you can also visit the New Zealand Ministry of Health website. They are really good. Thank you so much.
Yes. Thank you, Mrs. Anu.